everybody. Thanks for joining me for kind of a basic Cognitive Rehab 101 talk. So here's our agenda. I'm going to run through what cognitive rehab is, talk about who gets cognitive rehab, where this takes place, who the providers are, and then a little bit about strategies at the end. So beginning with what is cognitive rehab. So we have to first talk about what cognition is before we can really talk about cognitive rehab. Cognition is defined as the mental action or process of acquiring knowledge and understanding thought, experience, and the senses. That's a Wikipedia definition, but we use it because it's really easy to understand. APA says cognition are the processes of knowing, including attending, remembering, and reasoning, also the content of the processes, such as concepts and memories. So cognition encompasses knowledge, attention, memory, judgment, reasoning, comprehension, and language. And human cognition is conscious and unconscious, concrete and abstract, and intuitive. Without cognition, we cannot use existing knowledge and generate new knowledge. These are internal mental processes that may be tested with behavioral methods, but that are not directly observable. The physical mechanism of cognition involves two steps: the formation of connections between neurons in the brain and the sending and receiving of signals between connected neurons. Any factor then that interferes with these processes creates a barrier to cognition, what we call a cognitive deficit. And these skills, they may be lost or they may be altered due to brain damage that results from disease or injury. Cognitive functioning difficulties often affect behavior and the ability to complete everyday tasks, whereas other areas of healthcare focus on prevention and treatment of disease. Broadly, rehabilitation mainly focuses on the enhancement of human functioning and quality of life. So there's a connection between disease or injury and the ability to function. A disease may be cured, but a disability may remain. Disability can be reduced even with the presence of disease or permanent injury. Many people think of rehab as concerning improving physical disability, but rehab is not limited to this. Cognitive rehab attempts to enhance functioning and independence in adults with cognitive deficits or impairments that are the result of brain damage or disease, commonly following TBI or stroke, but often also after various types of illness. So cognitive rehab involves interventions that aim to lessen impairments or interventions that aim to lessen the disabling impact of these impairments. Cognitive deficits can be durable or temporary, as I alluded to. Durable causes include things like brain injury, such as a stroke or TBI or brain tumors, neurological disorders such as MS or epilepsy, congenital defects such as Down syndrome or autism, psychiatric disorders such as depression or schizophrenia, and temporary causes such as those caused by prescription drugs or recreational drugs or alcohol, nutritional deficiencies, and dehydration. And I'm going to talk briefly about just some of these causes today. Obviously, we can't cover the entire realm of cognitive rehab and cognitive deficits in 1 hour, but for an overview. So cognitive deficits usually affect a specific cognitive function. For example, about 80% of stroke and TBI victims will then have an attention deficit. About 65% will have a memory deficit, and about 75% will have executive function deficits. But attention and memory and executive function are the most common cognitive deficits, no matter what the cause of the deficit is. Each of the cognitive functions is associated with a particular area of the brain, and you can see that kind of starting here on the upper left in the frontal lobe. You have thinking, planning, problem solving, decision making. We call those like largely executive functions. This area is also responsible for impulse control or response inhibition. Down below that is the temporal lobe, which houses memory, speech, hearing, facial recognition. At the back of the brain is the occipital lobe, which controls vision and the processing of visual information. The parietal lobe controls perception, classifying objects, spelling, number recognition, and visual spatial processing. You'll notice that you don't see attention in any one location of the brain. If you were to try to find that, you would really be looking at all areas of the brain. There are attention areas in virtually every part of the brain, in the frontal lobe, the temporal, the parietal, the cerebellum, and the brainstem. And the functional areas are not limited. You see, we're just looking to the left side at the left side of the brain. Of course, the same functional areas are found in the right hemisphere. So generally speaking, both hemispheres can perform the same cognitive functions, and they usually share a workload, but there may be some specialization on particular tasks. There are a lot of diagrams available of the functional areas of the brain. This one is easy to understand, and that's why we use it often. If you want to look at a kind of more realistic diagram, it might look like this or something like this, with each area of the brain communicating back and forth with multiple other areas to perform a single function. But this really quickly becomes so complex that it's hard to discuss, and so we stick to a simplified model. So looking at some of those causes again, looking at stroke first. A stroke is defined as the sudden damage or death of brain cells due to lack of oxygen caused by blockage of blood flow or rupture of an artery to the brain. Stroke is the leading cause of disability in the United States, and it's the fourth leading cause of death. There are, as you see, two types of stroke. A blockage of blood flow is called an ischemic stroke. And depending on the location of the blockage, an ischemic stroke can affect a very localized area or a broader area. If the blockage is in a smaller area, it will affect a small localized area and maybe only one specific cognitive function. If it's in a larger artery, maybe it will affect a broader area. And this could even impact multiple lobes and cause affect multiple cognitive functions. About 88% of all strokes are ischemic, and the other 12 are hemorrhagic, which is the rupture of an artery in the brain. Hemorrhagic strokes do tend to affect a broader area, which again can impact multiple lobes and therefore multiple cognitive functions. So basically only an ischemic stroke in a smaller artery will have a localized effect, and all others typically have a more global effect and may affect multiple cognitive functions. The duration of the blood flow interruption in the brain is what determines how severe the cell damage is. In general, an interruption of more than about 2 minutes will cause cell death, and that's usually irreversible. A shorter interruption can cause cell damage, which might be reversible. So pressure from a hemorrhagic stroke on neighboring areas can also cause cell damage, which might be reversible. The prognosis at 90 days after a stroke, about 60% still have a mild impairment, while almost 20% have severe impairment. And it's important to know that no matter where you live in the world, the major risk factor for stroke is age. And of course, with an aging population, we expect a significant increase in numbers of strokes. However, that being said, this is a picture of a woman named Jill Bolte Taylor. She was a neuroscientist who in 1996, at the age of 37, suffered a hemorrhagic stroke. She is here holding an actual human brain. She's giving a very fascinating description of her experience. This is a TED Talk that I don't have time to play for you in this webinar, but it's a really, really good one, and it's a really nice description of the effects of trauma on cognitive functions. Google and watch this excuse me, this TED Talk if you get a chance. Dr. Bolte Taylor has also written a book called My Stroke of Insight. As I mentioned, excuse me, her stroke was a hemorrhagic stroke, and as we discussed, those tend to be global. They affect several areas of the brain, so multiple cognitive functions. So these are some of the things that she describes in that TED Talk and also in her book. You can see those here, changes to her body perception. She felt like an outside observer. She felt like things were slowed down. There was sometimes a sense of euphoria, etc. You can see those, and I really, really wish that if you have an opportunity, you would go and Google and watch that TED Talk. Her recovery was pretty amazing. She's giving TED Talks now. And, you know, in the video, she makes it clear that it took her 8 years to fully recover. The old school of thought said that there was only a very brief therapeutic window for cognitive rehab, about 2 years at max, and that no improvements could be expected after that. But Dr. Bolte Taylor is Sorry, we have a big storm just starting. Dr. Bolte Taylor makes it very clear that that is not the case. Again, her recovery took 8 full years, and I think that's something we should pay attention to. Part of her recovery is from what we call restitution, the healing of damaged neural pathways, but a large part of her recovery was due to targeted, repetitive, supportive cognitive rehab. So again, looking a little bit at traumatic brain injuries here, defined as the sudden damage or death of brain cells due to a violent blow or jolt to the head or by an object penetrating the skull. TBI is the leading cause of death for anyone under the age of 45. This damage is caused by bruising, hemorrhaging, or the stretching of brain tissue. And because of the cause, TBIs tend to be global, affecting multiple areas of the brain and multiple cognitive functions. And then there can be injury to areas opposite from the area of impact, called a contre-coup injury. In the United States, motor vehicle and pedestrian accidents are by far the leading cause of all TBIs, accounting for about 50% of such injuries, and then falls and gunshots and assaults, and of course, sports and recreational accidents, assaults, trauma, work-related trauma, suicide attempts, etc., are some of the other leading causes. TBI occurs with disturbing frequency among Americans. Overall, about 1 million traumatic brain injuries are estimated to occur in the United States every year. Approximately every 15 seconds, someone in the U.S. sustains a TBI. Of these, about 375,000 are hospitalized, 50,000 result in death, and 100,000 individuals sustain moderate to severe brain injuries that will result in long-term, sometimes lifelong, disabling conditions. And this is only the number that's reported through ER visits. Many, many more go unreported and often receive no medical care. Other causes of cognitive deficits are diseases, specifically neurodegenerative diseases such as multiple sclerosis and dementia. These result often in a slow decline in cognitive function. There's about 400,000 MS patients in the United States, which is a lot, but the real 800-pound gorilla in the room of our healthcare system is dementia. There are currently more than 5 million cases in the U.S. The number one cause of dementia is Alzheimer's, and the predominant risk factor for Alzheimer's is, again, age. Of course, as the boomer generation ages, the number of dementia patients is dramatically increasing. Cognitive deficits have a significant negative impact on activities of daily living and on quality of life. Memory and planning problems affect dressing, grooming, cooking, all skills needed for independent living. Attention issues and visual processing deficits increase the risk of things like collisions and trips and falls. Cognitive deficits can cause mood issues and motivation problems, which again, in turn, affect all ADLs and therapies. Attention and memory deficits make things that you do just for normal entertainment, like reading and television and socializing, difficult. And then executive functioning problems such as judgment and impulse control often cause family problems, marital problems, work relationship problems. And then any cognitive deficit can affect patients' ability to drive or return to work. So we understand a little bit about cognitive deficits, but what can we do about them? During most of the 20th century, we really thought that brain structures were fixed, solidified after a critical period in early childhood, and that after that early period, if you experienced a brain trauma, it was really assumed that you just have to live with the cognitive deficits that were a result. But more recently, researchers have shown that the brain's physical structure and functional organization can and does change in adults. And this is a concept called neuroplasticity, the brain's ability to remold and rewire itself, so to speak. Neuroplasticity is a response to changes in behavior and environment and thinking or emotions, and it's the key to the key to this kind of restructuring is repetition. Our brain was designed to grow new structures and to create new pathways in the presence of damage or an environmental challenge, and rehab helps to change the brain and increase a person's function and skills. So you'll hear neuroplasticity also just called brain plasticity or cortical plasticity or even cortical remapping, but it's basically the changing of neurons, the organization of the networks and their function via new experiences. It allows the neurons or nerve cells in the brain to compensate for injury and disease and to adjust their activities in response to new situations or to changes in their environment. And this is an idea that was first proposed in 1890 by William James in the Principles of Psychology, but the idea was largely neglected for the next 50 years. During the 20th century, the consensus, as I mentioned, was just that the lower brain and neocortical areas were immutable in structure after childhood, and that the adult brain was hardwired with fixed neuronal circuits. But again, this belief is being challenged by new findings, suggesting that all areas of the brain are plastic even after childhood, and this neurogenesis, or birth of brain cells, occurs in the adult mammalian brain even into old age. And a surprising consequence of neuroplasticity is that brain activity associated with a given function can even move to a different location. This can result from normal experience, and it can also occur in the process of recovery from brain injury. And it's that neuroplasticity that's the fundamental issue that supports the scientific basis for treatment of acquired brain injury with goal-directed experiential therapeutic programs in the context of rehab approaches to the functional consequences of the injury. So recovery of cognitive functions can be aided with cognitive rehab therapy, which is defined as a therapy program to help cognitively impaired individuals restore normal functioning or to compensate for cognitive deficits. And there are specific therapies designed for each of the cognitive functions. One way to look at restoring cognitive functions is or one way to talk about the ways that they're restored is to think about them in these terms. Restitution, which is the reestablishing and strengthening of damaged neural pathways. This is a healing process, and it applies in situations where neurons are damaged but not dead. Another way would be reorganization, developing and strengthening new neural pathways. Again, that's a neuroplastic process, and it may involve a slight detour, so to speak, to go around a damaged area, or even a total reassignment of a cognitive function to a completely different area of the brain. And then another way of recovering cognitive function is compensation, and that is the use of new strategies or external aids. The most common of these are things like memory strategies or external memory aids like notes or day planners, calendars, watches, clocks, things like that. In terms of practical therapy, there's not any real difference between restitution and reorganization. Whether the old neural pathways are being repaired or new ones are being built, the results are the same. The neural pathway and the cognitive function are restored. Compensation, on the other hand, is used to deal with existing cognitive deficits without restoring neural function. Sometimes long-term use of internal strategies can induce reorganization in the areas being used, though. So the role of cognitive rehab in restoring cognitive function is to promote and accelerate restitution, and also promote and accelerate reorganization. And then it can be used to teach and practice internal compensation strategies, and teach and practice the use of external aids. So looking at some of the domains, now researchers have looking at attention, researchers have identified 5 different components of attention. There's alertness, which includes tonic alertness, the general level of awareness, and then phasic alertness, which is the ability to increase that level of awareness after some sort of a warning stimuli. For example, when you hear, okay, pay attention now. And then selective attention is the ability to focus attention onto a particular stimulus while ignoring other stimuli. Sustained attention or vigilance is just what it sounds like. It's maintaining attention on a stimulus or task. Visual spatial attention is the ability to change the attention focus from one stimulus to another, usually from one location in the visual field to another. And then divided attention is the ability to focus on 2 or more stimuli at the same time. And if you think about it, you'll see that normal activities do require specific components of attention, and 1 or more types of attention is necessary for pretty much all of the activities that people enjoy. Selective attention provides the filtering that's required for speech recognition and therefore necessary for socializing. Focused attention is needed for reading or hobbies. Sustained attention is required for understanding the content and context in movies, televisions, books, sometimes conversations. Shifting focus is required for things like crossword puzzles or other hobbies. Divided attention is needed for activities like dancing, which require response to multiple stimuli. So imagine how a disturbance in attention can affect a patient's quality of life. If the things that you enjoy the most, reading, television, hobbies, socializing, become so strenuous that a person begins to avoid them. And then that lack of healthy activity, of course, has a tremendous impact on physical health as well. If you look at the areas of the brain, the attention areas of the brain, again, a very simplified kind of definition or graph, but you can see at least 3 different areas, and they surround the center of the brain. The next cognitive function we want to look at is memory. And we're going to use just a real practical definition: the ability to encode, store, retain, and subsequently recall information and past experiences in the brain. And as you know, memory is, of course, necessary for learning. It is necessary for all ADLs. It affects all other cognitive functions. It, of course, affects cognitive rehab. And it's the 3rd most common area of deficit after a stroke or TBI, affecting about 65% of patients. Working memory deficits have a significant impact on overall cognitive skills, as I mentioned. In addition to just generally forgetting what you were doing, working memory deficits also affect basic skills such as problem solving and reading comprehension and calculating, reasoning, verbal comprehension. Looking at the memory areas of the brain, you see at least 4 areas in this Brodmann diagram. Notice that 3 of the 4 areas surround the center of the brain, and they're co-located with attention areas. The central executive, which kind of manages working memory resources, is located in the prefrontal cortex, along with the other components of executive function, which we're going to talk about next. We define executive function as the coordination of multiple cognitive functions to produce a coherent, goal-directed result. So kind of like a quarterback, which you sometimes hear, that in reference to executive function. The executive assigns cognitive tasks to attention, memory, language, emotional centers, and visual spatial processing, and then the executive coordinates their activity with the purpose of achieving a specific goal. So executive function is necessary for purposeful behavior. It's necessary for all ADLs. It directs all other cognitive functions, affects all cognitive rehab, and it's the 2nd most common deficit after a stroke or TBI, affecting about 75% of patients. This goal-directed purpose is unique to the executive. Attention kind of monitors the outside world without a goal. Memory kind of rehearses and remembers without a goal. Language or the language centers interpret without a goal. It's the executive that works with the purpose of achieving a specific goal. And so looking, again, at a very simplified diagram of executive functions, it would kind of look like this, with signals to and from many other parts of the brain. Again, this is extremely simplified. But the models that I'm showing kind of show the basic concepts, that the frontal lobes really don't act alone. The 3 prefrontal areas are essential for all of the executive functions. And you can then imagine that damage to each of the prefrontal areas can cause a fairly predictable set of specific executive deficits. Deficits in these areas are often underestimated or not perceived at all by the patient, and they're very, very difficult for family members and friends to understand and deal with. They can cause really significant problems with family and social and work reintegration, and those are some of the most common long-term effects of brain trauma. So looking at just a few more slides to show those 3 areas. We know that these 3 areas of the frontal lobe are necessary for various executive functions: the dorsolateral prefrontal cortex, the orbital frontal cortex, and the anterior cingulate. The dorsolateral is involved in information processing functions such as attention, working memory, and integrating cognitive functions. The anterior cingulate cortex is involved in motivation and anticipating rewards, emotional awareness and empathy, error identification, and impulse control. And then that 3rd area involved in executive function is the orbitofrontal ventromedial area of the prefrontal cortex. There's some debate about the exact borders between the orbital frontal and the ventral media, so they're just shown here kind of together. But this is the area that's involved in decision making. or the valuation of rewards and punishments, the evaluation of emotional experiences, including, for example, being embarrassed, emotional regulation, self-monitoring, and again, also in impulse control. So again, we've seen the three areas of the frontal lobe responsible for executive function. And I want you to notice that all three have one function in common, and that is response inhibition and impulse control. This is the don't do anything stupid function that is really underdeveloped in most teenagers, right? And notice how the functions are grouped. So if a patient has problems with decision making, you might also anticipate problems with emotional regulation, but not necessarily information processing, because that's a different area. Motivation issues might co-occur with the deficit in emotional awareness, but you would not necessarily expect sexual inappropriateness. Of course, again, this is a very, very simplified model that we're looking at. Let's look at visual spatial processing. Visual spatial processing is defined as the analysis of complex visual stimuli which allow us to perceive whole objects and the spatial relationships among them. This gives us an idea of what it is, but we also have to clarify what it is not. Visual spatial processing is not vision. It's not visual field. It's not the function associated with hemianopsia, neglect, or saccadic movement. It is not visual attention, the ability to focus attention on an object in space. Visual spatial processing is the cognitive processing of visual information that allows us to see objects in their entirety and understand the spatial relationships between objects. This is really our predominant method for processing information about the world around us. It's subconsciously driven, so it's kind of difficult to explain it to someone else or teach it or even intentionally initiate it, but it affects all other areas involved in cognitive rehab, and it affects all areas of activities of daily living. The frequency of impairment or deficit after stroke, or TBI, is 30 to 50% after a left hemisphere trauma and 50 to 70% after a right hemisphere trauma. In addition to interpreting visual cues such as size and shape, there's other visual spatial skills associated with objects. These include things like separating objects from a background, identifying an object when only part of it is visible, and being able to form a mental image of an object. Spatial skills include depth perception, assessing if an object is vertical or horizontal, mental rotation, both 2- and 3-dimensional, and then forming mental maps. Visual constructive skills include copying a drawing and assembling 2D and 3D objects. And I'm sorry, I see that I covered the drawing of the ray for purposes of the handout so that it wouldn't be in the handout. But then I forgot to uncover it before we posted this slide. So just above where it says copying a drawing and you see the person's drawing would have been the full Ray Osforth drawing. And this drawing on the lower left here is from a patient with a visual spatial deficit. Reading also requires processing of shapes and positions. Depth perception is needed for grasping objects. Orientation and navigation in the environment require mental mapping. Interpreting angles is necessary for reading a clock. Mental imagery and 3D assembly are needed even for dressing. Cooking requires visual spatial skills for filling pots. Estimating volumes and portions. Setting a table is a 2-dimensional construction that requires visual spatial processing. So you can see how important even this is, even to just activities of daily living. So therapies typically focus on the specific visual spatial pathway. For an object processing deficit, for example, the therapy would involve training on object information such as color, texture, shape, and size. And for spatial processing deficit, the therapy would involve spatial information such as location and movement and angles and 2- and 3D rotation and so on. The visual field is often a focus of cognitive rehab, so I want to talk about that quickly. Basically, it's the spatial array that is visible to a person without looking around. A visual field deficit is a loss of a portion of this visual field, and we're talking here about neurocognitive visual field deficits, that is, visual field deficits caused by a brain injury, illness, or trauma. Deficits in visual field are very common after ischemic stroke. But recovery of visual field after stroke is also very common. Only a few have long-term deficits. Visual field deficits are relatively uncommon after TBI, but TBI patients often have ocular or oculomotoric problems. And there is some concern, though, that visual field deficits could be significantly underdiagnosed in the TBI population. We've always heard that the occipital lobe is the vision center of the brain, but there are other areas of the brain involved in vision too, especially the posterior portions of the parietal lobe and the temporal lobe. Patients are often unaware of their own visual field deficits. They or their caregivers may notice that they bump into things or even people. Patients will often blame these kinds of problems on other causes like poor lighting. And if they do recognize that they have a visual field loss, they often think it is a vision problem. As an example, these are kind of scary pictures. The first one is scary enough. Two kids running into the street after a ball. And this is the view from an approaching car. And as you see, the driver here on the left has a relatively normal visual field. On the bottom right is a view for the driver with, or I'm not sure, I can never say this correctly, ordantenopia. Ordantenopia. This is a really scary photograph. This driver is completely oblivious to the children who are there, but the driver's brain fills this area in. This is the brain correcting the scene. These are pictures that illustrate the findings of a study that was done by A.M. Hosting. And the findings really kind of illustrate that defects are not really perceived as black clouds, but instead are concealed by the brain in patterns and colors that match the surround. And this work was based on glaucoma patients, but stroke or TBI patients often report this same kind of fill-in effect. We represent visual field deficits as black areas on a perimeter graph, and we assume it's like the patient is looking through a window with that pattern painted in black, but the patient may not perceive the black areas. Instead, their brains compensate and fill in those areas. And it kind of underscores that visual field screening is recommended for all cognitive rehab patients. Okay, so this is a slide that shows too that the occipital lobe, even though we've heard that it's the vision center of the brain, that there are other areas of the brain involved in vision too, that I mentioned a minute ago. And then one last defect, which is often confused with hemianopia, is hemispatial neglect. Hemispatial neglect, which is also called unilateral neglect or just neglect sometimes, is the inattention to or lack of awareness of one side of space. And it's an attention deficit, not a visual field deficit, but it is sometimes confused. Left hemispace neglect is very common after a stroke. It affects about 43% of patients who have right brain lesions. Right side neglect is less common and less persistent. It affects only about 20% of patients with left brain lesions. Recovery is very common. Only about 17% of right brain lesion patients and 5% of left brain lesion patients are still affected at 3 months after the stroke. The difference in left side and right side frequencies is because the left hemispace is only represented by the right brain, but the right hemispace is represented by both sides of the brain. So there's some redundancy in representing the right hemispace. The neglected space is usually contralateral to the brain damage, and the neglect often affects multiple senses, visual, acoustic, and tactile. Again, it's often confused with hemianopia, which is blindness over half of the field of vision, but it often co-occurs with hemianopia. It's often misdiagnosed, and it has an impact on ADLs similar to hemianopia, but it's not. Here's a chart that just shows the differences. This is in your handout. I'm not going to go through this, but you can see that there are some differences in hemispatial neglect and hemianopia. Okay, that is covering the domains and some of the areas that are commonly affected, and then hence the target of cognitive rehab. But before we talk a little bit about the types of therapies, let's look at who these patients are. Who gets cognitive rehab? So the brain, you can see some of the common patient symptoms are of those who need and then are suggested for or referred for cognitive rehab are decrease in intellectual functioning, slowed processing speed, memory loss and forgetfulness, difficulty with language, for example, word retrieval or comprehension, speech, emotional changes, changes in insight, attention and concentration changes, and difficulty with planning or multitasking. So the brain is responsible for producing all forms of human behavior, but the brain is a pretty fragile organ, and severe injury can create significant problems in behavior and adaptive functioning in society. After severe traumatic injury and some illnesses, there are several common long-lasting deficits in functioning that can occur. In general, individuals with severe brain injury are often unable to effectively be part of society for whatever portion of time their deficits render that difficult. They have trouble developing family and social relationships, and they can't fully participate in the life of a community because of these deficits. So there are, of course, many physical and behavioral characteristics of brain injury. I chose just to include the slide here with cognitive characteristics. You can see those here. They include impaired attention and concentration, memory impairment for learning and recall of new information, impaired problem solving and decision-making skills, slowed information processing speed, impulsive thinking without regard for consequences, poor organization, planning, and sequencing abilities, impaired concept formation and abstract thinking, inflexible thinking and mental rigidity, poor judgment, especially in social situations. Some of the types of behavioral and physical characteristics are things like physical. So for things that you would expect, right? Physical deficits can include paralysis or weakness in both the arms and legs, paralysis or weakness on one side of the body, impaired fine motor skills, sometimes with tremor, poor overall body coordination or ataxia, double vision, visual field cuts, as we talked a little bit about, and motor speech disorders. And then behavioral, of course, the inability to engage in purposeful activity or disinhibition, the inability to respond appropriately to environmental cues, social skills deficits, impulsivity, a denial of deficits, et cetera, et cetera. So let's look next at where cognitive rehab takes place and who the providers are. There are several models of rehab. In the past, rehab programs for people with brain injury were largely provided in a medical model. That is still predominant, but there's a trend that is toward more community and home-based rehab models. And as the average length of stay in hospitals and rehab facilities continues to fall, the importance of community services has really grown. Fortunately, providers of services are offering more community-based options. Most patients who receive cognitive rehab do so when their medical status has stabilized. Recovery and adjustment can occur over a trajectory of weeks, months, and years. Often rehab interventions really depend on the amount of time since the injury onset. And treatment approaches include comprehensive inpatient or outpatient programs, outpatient programs delivered by a sole practitioner, or comprehensive programs with multiple providers. There's really some debate about when and where to deliver cognitive rehab. Some advocate for early intervention, while others call for intervention at more chronic recovery stages. The Society for Clinical Rehabilitation recommendations for best practice include the recommendation that cognitive rehab be provided at every stage of rehab, even from just after the acute insult. So from coma to community, as appropriate, of course, for the needs of the individual with the brain injury. So inpatient, outpatient care, acute inpatient rehab unit, outpatient services, day treatment, residential or home programs, sometimes skilled nursing facility or residential nursing facility, home health care, and just home self-treatment. Some of the key components of cognitive rehab, wherever the location, it's really important that cognitive rehab is part of a multidisciplinary approach, not functioning as a standalone therapy. Thorough assessment using a standard battery should be administered in any setting that cognitive rehab takes place, each setting even. This should include, this battery should provide sufficient information that will allow the formation of hypotheses about the underlying cognitive impairments and deficits, and then the results of the battery would allow the therapist to make decisions about which treatments are necessary rather than just describing the problems. So the assessment instrument should provide more information than the patient has just a memory impairment. It should really enable the clinician to decide which aspects of memory should be targeted, for example. And then patient education about cognitive strengths and weaknesses. It should include clear goal setting and treatment planning in a person-centered approach. Intervention should involve the practice of functional tasks and the use of internal and external compensatory strategies. And then there should be continued reassessment of progress in various settings and across time, even different times of the day. And also continued evaluation of the mental health that goes along with this type of rehab. Providers of cognitive rehab pretty much run the gamut, as you might expect. Because of the breadth and the complexity of problems following TBI, many different types of medical professionals often become involved in the direct care of a particular individual. And these professionals may be involved at all levels of care in the recovery process. Some of the common types, of course, are physicians. Initially, emergency room and trauma physicians may be involved, and then neurosurgeons and neurologists become the primary care physicians in the hospital. In a rehab unit, a physiatrist will usually be the physician directing treatment, and then consultants can include psychiatrists and neuro-ophthalmologists, internists, urologists, other medical specialists as needed. Physicians are usually charged with the overall care of the individual from a legal standpoint. Of course, nurses are involved at all levels of care, including at home. Physical therapists, they provide comprehensive assessments of physical body functioning and provide movement and exercise therapy for the lower extremities in particular to facilitate recovery of strength and coordination and speed of muscular activity. Their therapies typically range from passive range of motion to guided and active range of motion, strengthening exercise, assistance in walking. They look at movement dysfunction and they evaluate and diagnose movement dysfunction and then use interventions to treat. And then occupational therapists who do a comprehensive assessment of physical body functioning also, but focus largely on the upper extremities and perceptual or visual skills. Occupational therapists also provide crucial assessment and training in doing ADLs, such as eating and meal preparation and driving. They help patients regain functioning within home, work, or school or community settings. And they often focus on looking at the impact of the impairments on everyday activities. Speech therapists, of course, focus on the treatment of speech, language, and cognitive disorders, including things like swallowing and speech, of course. And then a neuropsychologist is a key player, or rehab psychologist sometimes, is a key player in diagnosing cognitive impairments and emotional and behavioral sequelae of TBI or brain injury illness as well. A neuropsych assessment evaluates the areas of intellectual functioning, judgment and concentration, problem solving, attention, memory and learning, and flexibility of thought and speed of information processing. Of course, these kinds of evaluations are what are used to help patients and families understand the nature and severity of the deficits and then assist other team members when planning treatment programs. And there's a variety of approaches that are used aimed at helping individuals through the individual, family, or group therapy, and then designing and implementing behavior modification programs along with the cognitive rehab strategies. Many other types of allied health providers that I'm leaving out here: social workers, recreational therapists, audiologists, kinesiotherapists, neuro-ophthalmologists, rehab counselors, many providers. So the goals of cognitive rehab are to enhance the person's capacity to process and interpret information and to improve the person's ability to function in all aspects of family and community life. Restorative training that we've talked about focuses on improving a specific cognitive function. Compensatory training focuses on adapting to the presence of a cognitive deficit. Compensatory approaches may have restorative effects at certain times, as I mentioned earlier. Some cognitive rehab programs rely on a single strategy. Sometimes something like computer-assisted cognitive training might rely on a single strategy, while others use an integrated or interdisciplinary approach. If it's a single strategy program, it can target either an isolated cognitive function or multiple functions concurrently. But the overall aim of cognitive rehab is to reduce the impairments caused by whatever the damage has been to the brain. The aim is for the patient to achieve as much independence as possible through as much of his or her own means as possible. And then the main criteria of success depends on the specific goals of the patient, the patient's subjective opinion about the change of his or her quality of life. And then those goals can be tailored to enhance the individual's ability to function as independently as possible in the least restrictive setting. But with the end result being to improve quality of life and real life skills. So as I mentioned, studies have divided cognitive rehab therapy into components, and so we talk about them in terms of restorative and compensatory approaches, retraining or restoring cognitive processes that have been impaired by the injury or illness. Damaged circuits may be able to be retrained if they've been partially or substantially spared after an injury or illness. This is sometimes called process training. This approach aims at reinforcing, strengthening, or restoring the impaired skills, and it includes the repeated exercise of standardized cognitive tests of increasing difficulty targeting specific cognitive domains, for example, selective attention or memory for new information, those that we've gone over today. The purpose of process training is to stimulate poorly functioning neurological pathways in the brain in order to maximize their efficiency and effectiveness. It aims to overcome that damage, and functional improvements can be made over many months or even years. And then the compensatory approach teaches ways of bypassing or compensating for the impaired function, the development of new compensatory skills to enhance the daily performance. And here, retained skills and functional reorganization are both used to learn new strategies. This is sometimes also called strategy training, and it may involve the use of external tools, as I mentioned, diaries, electronics, or adaptive equipment, assistive technologies, calendars, electronic memory devices, alarms, those kinds of things as compensatory techniques. These aren't mutually exclusive, and they really should be undertaken at the same time. Treatments that attempt to restore lost function should be undertaken at the same time as teaching the compensatory strategies in order to minimize the cognitive impairment. In addition to process training and strategy development, education and functional application are really important in the cognitive approach, in the cognitive rehab approach. It's important, though, that all interventions have these characteristics, that they be structured, that they be systematic, that they be goal-directed, that they be individualized to fit the patient's specific needs and goals, that they involve learning and practice and social contact and in a relevant context, and that they be repetitive. It is those characteristics that allows them to be successful. Again, these are just the areas, the cognitive skill areas that are targeted. I'm going to go over some of the different types of therapies in just a second, but looking at them in this division with attention skills, including sustained, selective, alternating, or divided, like we talked about earlier, visual processing, acuity, oculomotor control, visual attention, scanning, visual memory, pattern recognition, things like that. Information processing, including auditory and other sensory processing skills, organizational skills, speed, the capacity of processing, memory, of course, including orientation, episodic, prospective, encoding, storage, consolidating, and recall. And then executive skills, including things like self-awareness and goal setting, self-initiation, self-inhibition, planning and organization, self-monitoring, self-evaluation, flexible problem solving, and metacognition. You can see how many areas there are, even within just these 5 domains, and how many different types of strategies that could require. So some of the strategies include process training, which stimulates poorly functioning neurological pathways in the brain in order to maximize their efficiency and effectiveness. It really aims to overcome the damage. This is not general stimulation or drill training. It really relies on a good comprehensive assessment and an analysis of the results that leads to the results, or that leads to the awareness of which component, skill, or cluster of skills is impaired so that it can be targeted. And then a task or series of tasks is designed to develop and improve those specific impaired skills. So if that approach is successful, then any real life skills that rely on that underlying or impaired skill would improve as it improves. Process training exercises really should be extensive to target those particular, or whatever the particular kinds of impairments are. It should work towards generalization of the skill by using multiple exercises, often targeting the impairment in slightly different ways. And process training should be used in conjunction with strategy training, which involves teaching compensation strategies, as I mentioned earlier, using mnemonics internally that can't be observed by others, using visualizations and word associations, and then external strategies, such as using things that are external to the person, like alarms and notebooks and notes and calendars. It's easier to teach these external kinds of things first. The internal do require greater cognitive capacity because the strategy has to be remembered at the very time when the person is beginning to struggle with the task. And that's usually when they're becoming overloaded, of course. Functional activities training focuses on improving real life functioning, as you might think. It's used as a vehicle within which to treat the cognitive skill deficits and to train the person to complete a particular functional task. So the patient really should help create these goals because they should be goals that are valuable to and important to the particular person in their life. But it involves breaking down functional activities into their component parts and then relating these to the process training and the strategy training components. Cognitive rehab interventions are applied through technology often and other compensatory strategies that may allow the individual with cognitive impairment to accomplish important life activities and then more fully participate in society. So cognitive exercises, including computer-assisted strategies, are often used to improve specific neuropsychological processes, predominantly attention and memory and executive skills. There are computer-based tools that include things like virtual reality, which allows the patient to interact with a computer-simulated environment to help improve working memory or selective attention or sustained memory or divided attention. Other computerized tools include types of software, computer software that allows work on different cognitive abilities, visual memory, verbal memory, attention to visual objects, things like that. And then compensatory strategies include making changes in the environment or adopting different methods of performing activities, as we've mentioned, or the use of devices that help remember things. Interventions in cognitive rehab are being developed rapidly, and they've only recently been subjected to scientific inquiry. The efficacy of cognitive rehab so far has been measured mostly by its objective influence on function and the subjective value of these changes to the individual. So we define computer-assisted cognitive rehab as a computer-based tool to help therapists deliver targeted cognitive tasks and exercises. And here you see some targeted, repetitive, and supported types of things. Targeted meaning that it addresses the most common cognitive deficits, attention, memory, and executive function, and so on. And targeted means that it's appropriate for patients with severe deficits or moderate deficits or mild deficits. And so for this reason, brain training is not cognitive rehab, and computer games are not cognitive rehab. Computer-assisted cognitive rehab can target cognitive functions that are difficult to train with manual cognitive rehab. And again, we have attention, memory, and executive function. But with a computer, you can easily and effectively train visual field, visual spatial processing, and a special type of visual spatial processing, face recognition. Okay, sorry, the slide just told me we have 5 minutes, so I'm going to finish. We move to memory therapy. For mild and moderate impairment, the recommended therapy regimen includes working memory training with strategy training. Some common strategies include mnemonic devices, PQRST, vanishing cues, errorless learning, and spaced retrieval. Visual field therapy. Visual field deficits are often amenable to reorganization, and so the therapy for this is called visual restoration training, and that produces light stimuli in the area along the border of the deficit. And the idea is that it helps stimulate reorganization of neural pathways near the damaged area of the brain, and it's been shown to expand the visual field up to about 12%. There is some controversy about whether this improvement is through reorganization in the brain or if the patient's learning unconsciously to quickly shift their fixation point by a few degrees, but in either case, the result is the same. The patient's perceived visual field is expanded by several degrees. And this is for about 90% of patients who receive this training. And so that can have a pretty significant effect on ADLs. Visual field deficits can also be compensated by improving the scanning pattern of the eyes. This is a therapy called saccadic training, and its goals are to expand the range of eye movement into the area of the visual defect and to improve the speed of detection by developing a more efficient scanning pattern. And this is also a highly effective therapy. This picture just illustrates spontaneous restitution. These are self-portraits by an artist after he suffered a stroke in 1967. And you can see that his awareness of the left hemispace increased over 8 months. Just really like that illustration. These are just some examples. Drill and practice uses repetitive practice to develop cognitive abilities. I'm not going to go through all of these. You can see them: drill and practice, recall strategies, and then some more specific interventions. And then I have about 3 or 4 slides that cover some of the evidence for cognitive rehab. The Cognitive Rehab Task Force of ACRM conducted a meta-analysis of systematically reviewed 46 Class 1 studies, 43 Class 2 studies, and 169 Class 3 studies of cognitive rehab for people with TBI and stroke. And their overall analysis of 47 treatment comparisons from Class 1 studies representing 1,801 patients indicates that cognitive rehab is of significant benefit when compared with some alternative treatments. They made some recommendations that should help guide clinical treatment and facilitate additional research, but overall the meta study found significant evidence to support cognitive rehab for attention, memory, executive function, visual spatial processing. I said, yep, all of those. This is the from that same study, evidence-based recommendations for cognitive rehab, the practice standards and practice guidelines. And then just a summary slide here, because the webcast will end directly it will close in 2 minutes. So I just want to get to the summary slide. Cognitive rehab really should be context specific. We really want to train the person in their home, their community, their workplace, where they need to be living their life. It should utilize their natural supports, and it should collaborate with those natural supports and with the individual, working on what they want to work on and helping them think through their choices. It should emphasize strategy training to compensate for residual deficits, reduce disability, and restore social role functioning, establish relevant functional outcomes, and it should not focus on eliminating the underlying cognitive impairment. Instead, it should be directed toward improving everyday functioning and include attempts to promote generalization or directly apply compensatory strategies in functional contexts. And it should concentrate on long-term maintenance of improved functional outcomes, include continued support and intervention for patient and family. Family is really key to cognitive rehab. And so for a patient who has the family support, they should be encouraged to participate and be a part of the cognitive rehab. So the overall goal of the rehab is to improve functioning and quality of life. And I think we've given an overview. There is a lot more that could be said about cognitive rehab, but I hope I've been able to give you some basic information today. Thank you.